Usually, when you step into the operating theater, there's this underlying expectation of total control, you know?
Oh, absolutely. Yeah.
You prep the patient, you make the precise incision, and if you need a bloodless field, well, you're the one who applies the tourniquet.
Right. You dictate the pressure.
Exactly. You monitor the exact time. It's this highly calculated environment, and it is entirely in your hands.
Yeah, the whole surgical discipline is built on that, right?
Ugh.
Dictating the terms of the anatomy we're working on. We rely on that predictability to actually execute these complex reconstructions.
But then you step into the world of congenital anomalies, specifically today's topic, and suddenly that control is it's completely stripped away.
Yeah, it really is.
Because we're looking at a clinical landscape where nature has already applied the tourniquet in utero, completely unsupervised, and just left you to manage the aftermath.
Left you with a mess,
Yeah.
essentially.
Right. So, welcome back to another revision deep dive. This session is designed specifically for you, the plastic surgery resident preparing for board exams like the FRCS. And we are getting straight to the high-yield facts today.
You have to, because the margin for error in these board exams is notoriously slim. I mean, you need to recall these concepts rapidly and articulate the underlying anatomical logic flawlessly.
Flawlessly. But really quickly, before we jump into the clinical material, make sure you press follow on your app right now so you never miss a revision deep dive.
Definitely.
And hey, if you find this breakdown helpful for your studies, take a second to rate the show. Also, for those of you looking to take your preparation to the absolute highest level, get a premium subscription.
That's where the real granular stuff is.
Yeah, that is strictly where you go to listen to our journal club and clinical cases episodes, so highly recommend that. Okay, today we are focusing on constriction ring syndrome.
Widely known as amniotic band syndrome, of course.
Right. And we're running a rapid-fire Q&A style review covering its presentation, classification, and surgical management. So, to treat a condition, you obviously must first recognize its scope in the clinic. Let's define the parameters here. Break down constriction ring syndrome for the listener and detail its immediate physical manifestations.
Sure.
Like, what are we actually looking at when this child presents?
Well, at its core, constriction ring syndrome is characterized by the formation of partial or complete circumferential constrictions around the developing limbs or digits.
Okay.
So think of these amniotic bands acting like tight, unyielding ligatures around rapidly growing tissue. And because of this mechanical strangulation, you basically see three primary, very distinct clinical issues.
Right.
First, you have acrosyndactyly.
Yeah.
Second, you see terminal absence or intrauterine amputation of the affected limb or digit.
Right.
And third, you have localized swelling, so significant edema distal to those constrictions.
Acrosyndactyly, amputations, and distal edema. I'm going to pause on the edema for a second, actually. Because a board examiner isn't just going to ask what it is, they're going to ask why it happens. What's the physiological mechanism driving that localized swelling?
So it comes down to a fundamental vascular hierarchy.
Yeah.
I mean, arteries have thick muscular walls, and they operate under high pressure.
Right. The inflow is strong.
Exactly. But veins and lymphatics are thin-walled, low-pressure systems. So when that unyielding amniotic band tightens around a limb, it compresses the low-pressure systems first.
Ah, so the outflow gets cut off.
Yeah, the lymphatics and the venous outflow are completely blocked off. But that high-pressure arterial inflow, it continues to pump blood right into the distal limb.
Wow.
And this creates massive hydrostatic pressure distal to the band. It forces fluid into the interstitial space, which presents clinically as severe, sometimes even limb-threatening edema.
That makes perfect mechanical sense based on that tourniquet analogy we used. The inflow remains open, the outflow is choked, and the downstream tissue just becomes completely engorged.
Exactly.
So how often is a resident actually going to encounter this syndrome in practice?
Well, it occurs sporadically. The incidence you really need to commit to memory for the exam is 1 in 15,000 live births.
1 in 15,000.
Yeah. So it's rare enough that you might not see it every single week in the clinic, but it's an absolute favorite for examiners. Because of the really unique reconstructive challenges it presents compared to other congenital anomalies.
Right. And the real trap for a resident here isn't just diagnosing the rings on the limbs. The sources highlight our really high-yield exam fact. 50% of these cases are associated with other anomalies.
Oh, yes. The examiner will inevitably ask you to list them.
Right. And the literature points to talipes equinovarus, cleft lip and palate, hemangiomas, and cranial or cardiac defects. But if I'm sitting in the hot seat, I want to use a rule of 50% mnemonic prompt to organize my thoughts.
That's a great strategy.
So how should a resident logically group these associated anomalies to ensure they present a structured answer?
Well, examiners do not want to hear a scattered, memorized list. They want to see systematic anatomical thinking. So, using your rule of 50% framework,
Right.
you state clearly that 50% of cases have associated anomalies.
Okay, step one.
Then you compartmentalize anatomically. First, address the extremities. So you mentioned talipes equinovarus. Second, move up to the face. You explicitly list cleft lip and palate alongside hemangiomas.
Extremities, then face. Got it.
And finally, you broaden your scope to the systemic and central issues. So you highlight the potential for cranial or cardiac defects.
Limb, face, systemic. Talipes, clefts, and hemangiomas, cranial, and cardiac. Okay, but I need to challenge this grouping for a second.
Go for it.
If a patient presents with anomalies across the limbs, the face, and the heart, I mean, that usually screams of a systemic genetic mutation or some kind of chromosomal syndrome. Is constriction ring syndrome a genetic issue?
That is a brilliant distinction to make in Aviva, and the answer is no. It's generally not considered a genetic or chromosomal abnormality. It's actually a sequence of mechanical disruptions. The current prevailing theory is the extrinsic model.
Meaning the environment in the womb physically causes these diverse issues rather than a flawed genetic blueprint.
Yes, exactly. So, for example, the talipes equinovarus, the clubfoot, that often occurs because the initial rupture of the amniotic sac leads to a loss of amniotic fluid.
Oh, oligohydramnios.
Right, oligohydramnios.
Right.
And without that fluid, the fetus is cramped against the uterine wall, which physically restricts joint movement and causes the foot to develop abnormally.
Wow, okay. And the clefts?
As for the cleft lip or palate, the theory is that an amniotic band might actually be swallowed by the developing fetus.
Wait, literally swallowed?
Yeah, and it physically obstructs the fusion of the facial processes. So it's a mechanical accident resulting in this really wide array of physical defects.
Man, if we're seeing this distinct pattern of distal swelling, intrauterine amputations, and mechanically induced facial clefts, it really forces us to look closer at the womb itself.
It does.
So what exactly is misfiring in the amniotic environment to create these rogue bands? Let's dive into the etiology.
Okay, the primary etiology you must state is the early rupture of the amnion, so the inner layer of the embryonic membrane, while the chorion, the outer layer, remains intact.
So the inner layer tears.
Right, and this disruption occurs early in gestation. When the amnion ruptures, it sheds these tough, fibrous strands of mesoderm, and these rogue amniotic bands just float freely in the amniotic fluid.
Just waiting to cause trouble.
Exactly. Eventually, due to fetal movement, they encircle the developing limbs, digits, or facial structures of the fetus.
So the bands wrap around the tissue, and as the fetus rapidly grows, the bands just don't. They remain fixed.
Yes.
And that physical mismatch creates the notch-by-notch tightening effect, which perfectly mirrors how we classify the severity of the condition. So walk us through Patterson's classification.
Sure. So Patterson's classification is the gold standard here, divided meticulously into 4 stages. Stage 1 is the most basic presentation, simple constriction rings. You have a visible ring, like a groove in the soft tissue, but the distal anatomy is otherwise functionally and structurally unaffected.
So just a surface groove.
Right. Then stage 2 progresses the severity. You have rings accompanied by distal deformity. And importantly, this stage may or may not include the severe lymphedema we discussed earlier,
Depending on how deep it goes.
depending on how deeply the venous and lymphatic channels are compressed. Yeah.
Okay, so the tourniquet is now tight enough to cause structural deformity and fluid backup, but the individual digits or limb parts are still distinct from one another. What happens at stage 3?
Stage 3 is defined by rings accompanied by distal fusion. Clinically, this is where you see acrosyndactyly.
The fusion of the digits.
Yeah, the digits have been squeezed together and fused distally by the constrictive force of the band.
Yeah.
And finally, stage 4 is the endpoint of that constrictive process, intrauterine amputations.
The absolute worst case.
Right. The band has tightened to the point of complete vascular occlusion and tissue necrosis, literally severing the distal part of the limb or digit in utero.
Simple rings, rings with deformity, rings with distal fusion, and amputations. Stages 1 through 4. But I need to stop you on stage 3 for a second. Acrosyndactyly.
Sure.
Because standard syndactyly is a failure of apoptosis, right? The webbing between the fingers just never dissolves during weeks 6 to 8 of gestation.
Exactly.
So how does a mechanical band cause digits that presumably already separated to suddenly fuse back together?
Okay, this is high-level embryological distinction that will really impress an examiner. In acrosyndactyly caused by amniotic bands, the digits actually do separate normally during embryogenesis. The apoptosis occurs.
Oh, really?
Yeah. But then the band wraps tightly around the tips of those newly separated digits. The band causes local tissue ischemia, necrosis, and essentially creates raw open wounds on the adjacent fingers.
Oh, I see. And because they're pressed tightly together in the confined space of the womb, those raw surfaces just heal together.
Yes, they fuse secondarily, and this creates a very distinct clinical presentation. Because unlike standard syndactyly, which is fused from the web space downwards, acrosyndactyly often features distal fusion at the tips.
Ah.
But you will frequently find small epithelialized clefts or sinus tracts proximal to the fusion, which represent the original, normally formed web space.
That is fascinating. The digits separated, got guillotined at the tips by the band, and healed together at the stumps, leaving a tiny tunnel beneath the fusion.
Exactly right.
That perfectly clarifies stage 3. Now, if an examiner asks you to contrast the fundamental anatomical difference between Patterson's stage 3 and stage 4, what is the core concept the resident needs to highlight?
You must clearly distinguish the presence of distal tissue. The fundamental difference is fusion versus complete loss.
Okay.
In Patterson stage 3, there is tissue distal to the constriction ring that survives, albeit fused due to the mechanism we just discussed.
Yeah.
But in Patterson stage 4, there is zero distal tissue.
It's just gone.
The constriction resulted in complete vascular cutoff. The line of the ring is the absolute terminal end of the limb.
Right. Okay, so armed with a deep understanding of Patterson's classification, the resident must now articulate the surgical plan. This is where we move from observation to intervention. Let's navigate the surgical principles, starting with timing and urgency.
Okay.
When does constriction ring syndrome become an absolute surgical emergency?
Digital or limb ischemia at birth is the absolute red flag, though you must note that presenting with active ischemia at birth is actually quite rare.
Rare, but serious.
Very. If a newborn presents with a limb that is blue, cold, and poorly perfused due to a tight band, it demands immediate emergent surgical release in the operating theater.
But the resident needs to manage clinical expectations in this scenario, right? I mean, you rush the child to the theater, you release the band. Does the limb suddenly pink up and survive?
Unfortunately, no. While it requires an emergency attempt at surgical release, you must clearly state that the distal limb rarely survives in these ischemic presentations at birth.
Because the damage is already done.
Exactly. The vascular damage and tissue necrosis have usually been ongoing in utero for weeks or months. The damage is often irreversible by the time of delivery.
Because of that grim prognosis at birth, there is an evolving frontier here that residents should be aware of, right?
Yes. For severe cases identified early via prenatal ultrasound, especially those threatening a major limb centers of expertise have successfully released these bands fetoscopically.
Intervening surgically inside the womb.
Yes, before birth. It can sometimes salvage the limb before that irreversible ischemia or amputation occurs.
That covers the emergent and the in utero interventions. But for the vast majority of non-ischemic rings, so the Patterson stage 1 and 2's treatment is elective.
Right.
It's done to improve cosmesis and preserve future function as the child grows. What is the standard surgical approach for releasing the ring itself?
The standard approach requires the complete excision of the fibrous constriction band down to healthy tissue, followed by a specific soft tissue release. You cannot simply cut the band and suture the skin back together in a straight line.
You have to break it up.
You have to break up the linear scar using Z-plasties or W-plasties.
Let's visualize that for the listener. Why can't we just do a linear closure? If the band is gone, isn't the problem solved?
Well, a straight line scar running circumferentially around a limb will not grow at the same rate as the surrounding healthy pediatric skin.
Ah, of course.
So as the child grows, that circular scar will act like a purse string, creating a secondary iatrogenic constriction ring.
So you basically replace nature's tourniquet with a surgical tourniquet.
Precisely the danger. Z-plasties and W-plasties solve this by recruiting adjacent lateral tissue to lengthen the scar and, crucially, by changing the vector of tension.
Breaking up the forces?
Right. By breaking a straight line into a series of geometric angles, the scar can stretch and accommodate the circumferential growth of the child's limb without tethering.
Soft tissue is one challenge, but we need to discuss the neurovascular structures trapped beneath that scar. Nerve management in constriction ring syndrome is notoriously difficult. Why is that?
It comes down to the pathophysiology of nerves under chronic mechanical duress. Nerve palsies are incredibly difficult to treat here. Because, in a traumatic injury like a knife wound, you have a clean proximal stump and a clean distal stump to graft or repair.
Right.
But with an amniotic band, the constrictive force is applied slowly over months. This causes severe compression neuropraxia, which often progresses to axonotmesis.
Meaning the nerve fibers themselves degenerate distal to the compression site.
Yes, Wallerian degeneration occurs. And because the distal end organs, so the muscles and sensory receptors, are isolated from their nerve supply for so long during early development, the distal nerve trunk simply may not exist by the time the child is born.
It just disappears.
It may have atrophied into a microscopic fibrotic cord that is impossible to find, let alone repair.
That is a crucial anatomical caveat to mention in Aviva. Now, let's address a classic board trap regarding the safety of releasing these rings. Traditionally, textbooks taught that you must release no more than half the circumference of a ring in one sitting.
The two-stage approach.
Right. You do 180 degrees, wait a few months, and then do the other 180 degrees. The fear was that a 360-degree incision would cut off the only remaining collateral blood supply and cause distal ischemia. Is that still the standard of care?
It is not. And this is exactly where examiners will test if you are reading outdated materials or current literature.
Okay.
The modern updated standard you must state is that complete single-stage circumferential release can be performed safely.
Wait, I need to push back on that. If the deep venous system is already choked by the band, the limb is surviving on tiny superficial collateral veins just under the skin.
Right.
If you take a scalpel and make a 360-degree incision around the limb to perform your Z-plasties, aren't you dividing all those superficial collaterals? Why doesn't the limb die?
It's a very logical concern, but clinical evidence shows otherwise. The key is the depth of dissection.
Okay.
When you perform the complete circumferential release, you are excising the fibrous band and mobilizing the skin flaps. But the subdermal vascular plexuses are robust enough to maintain perfusion if the surgical technique is meticulous.
So you're not cutting as deep as people feared.
Right. Furthermore, by completely removing the deep constricting band in one go, you immediately relieved the profound venous congestion that was choking the limb in the first place.
Oh, wow.
So the net gain in vascular flow from removing the deep chokehold actually outweighs the risk to the superficial skin collaterals.
That is a massive paradigm shift. Complete circumferential release actually improves the overall vascular environment instantly.
Instantly.
So to the listener, do not fall into the trap of saying you must stage every single ring release. State the historical context to show breadth of knowledge, but confidently follow it up with the current single-stage standard. Let's move into our final segment. Reconstructive strategies for the most severe Patterson stages, stages 3 and 4. Moving from the soft tissue release of the bands to complex structural reconstruction. Let's start with stage 3 acrosyndactyly. What are the reconstructive rules of engagement here?
Well, the beneficial aspect of acrosyndactyly for your exam prep is that you do not need to invent a new surgical algorithm.
That's a relief.
Yeah. The reconstructive principles for managing Patterson stage 3 are essentially the same as those for standard syndactyly.
Okay, so standard flaps.
You're utilizing your standard dorsal or volar flaps to reconstruct a deep, functional web space using full-thickness skin grafts to cover the raw lateral borders of the separated digits, and obviously ensuring you do not compromise the neurovascular bundles during separation.
Right. Apply your rigorous standard syndactyly knowledge to Patterson stage 3. But Patterson stage 4, the intrauterine amputations, this is where the reconstructive logic takes a fascinating turn.
It really does.
We're talking about digits or entire limbs that are simply gone, but they are fundamentally different from other congenital absences. How?
This is the critical distinction you must make. Consider other congenital causes of absent digits, like symbricodactyly or a transverse arrest.
Okay.
In those conditions, the entire limb bud failed to develop properly from the very beginning. The biological blueprint was flawed.
Right, from day one.
As a result, the proximal anatomy is often severely hypoplastic. The forearm bones might be small, the flexor tendons might be missing, and the major vessels are often abnormal or absent. But intracranial amputations caused by amniotic bands are entirely different.
Because the blueprint was perfect. Nature's tourniquet was just applied to an otherwise normally developing limb.
Yes, the band acts like a highly localized guillotine. Because of that, intrauterine amputations have completely intact proximal structures. The tissue immediately proximal to the band was subjected to normal intrauterine development, normal arterial flow, and normal venous return. The proximal bones, the tendons, and the neurovascular bundles leading right up to the line of amputation are anatomically normal and robust.
See, I have to challenge that assumption. If a band is tight enough to literally amputate a digit, wouldn't the sheer crushing force destroy the tissue for centimeters proximal to the ring? Why do we assume that proximal anatomy is pristine and ready for surgery?
Because the amniotic band is incredibly narrow. It is often a thin, wire-like strand of fibrous tissue.
Ooh, like a cheese wire.
Exactly. The zone of injury is incredibly localized. It doesn't cause a wide crush injury like a heavy industrial press. It causes a focal line of ischemia. The tissue, even a millimeter proximal to that fibrous strand, remains well perfused and develops normally throughout the rest of the pregnancy.
And that biological reality changes the entire surgical game.
It does.
So if a resident is asked to justify a toe-to-hand transfer for a Patterson stage 4 amputation versus a typical congenital hypoplasia, what is the exact anatomical rationale they must deliver?
The rationale you must state is this. Because the proximal bone, tendon, and neurovascular structures are entirely intact, it provides the perfect anatomical recipient bed.
Perfect bed.
This makes microvascular toe transfer an incredibly viable option for the restoration of function. You have large, healthy recipient vessels to anastomose, strong functional tendons to provide motor excursion, and solid cortical bone for rigid fixation.
You're essentially plugging a newly transferred digit into a fully functional, pre-existing anatomical socket.
That's exactly it.
Intact proximal structures. That is the golden phrase. You must anchor your answer with it. It justifies the microsurgery and the complexity of the toe transfer. Let's do a rapid recap of the entire journey to cement this clinical picture for the board exam.
Let's do it.
We started with the etiology early amnion disruption, shedding mesoderm bands that encircle the limb. We moved through Patterson's classification, stage 1 simple rings, stage 2 rings with distal deformity and lymphatic backup, stage 3 acrosyndactyly caused by distal fusion of necrotic tissue, and stage 4 complete intrauterine amputations.
Spot on.
We discussed surgical timing, rare digital ischemia at birth demands immediate release, but generally we operate electively utilizing Z or W plasties to prevent iatrogenic purse string contractures. We busted the historical myth of staging, confirming that single-stage complete circumferential release is safe due to robust subdermal plexuses.
Yep.
And finally, we covered reconstruction managing stage 3 like standard syndactyly and leveraging the intact proximal anatomy of stage 4 to perform functional toe transfers.
That is a really comprehensive, high-yield summary. Honestly, if you can walk an examiner through the underlying pathophysiology of those stages and justify your surgical choices with anatomical logic, you will easily secure top marks.
I want to leave you with a final thought to mull over as you continue your revision. Consider how that concept of intact proximal anatomy in a Patterson stage 4 amputated limb fundamentally changes your entire reconstructive algorithm.
It changes everything.
Think back to our opening discussion about control in the operating theater. Unlike genetic conditions where the fundamental blueprint of the limb is faulty and you're searching for adequate vessels or missing tendons, here you have perfect anatomical building blocks right up to the line where nature applied that tourniquet.
Exactly.
How might that reality influence the exact placement of your preoperative markings? How does it change the confidence with which you perform your recipient site tissue dissection, knowing normal, large caliber vessels are waiting for you just proximal to the scar? Let that physiological reality dictate how you study your anatomical cross-sections tonight.
Good luck to everyone studying.
That wraps up today's session. But we want to hear from you. Drop down into the comment section on your app and leave a comment or a question about today's review. Did the mechanical explanation of the rule of 50% grouping clarify things? Are there other complex classifications you need broken down before your exam? Let us know. Keep studying hard, trust your preparation, and we will see you on the next revision deep dive.